time the blood uses up oxygen, how many? Three, right? Which brings me to cigarette smoking. So, in cigarette smoke, every cigarette smoke has carbon monoxide. So, what does carbon monoxide do? It bumps off the oxygen, right? So that's why cigarette smokers, see, this explains why cigarette smokers are always at increased risk of becoming cardiac patients. Does it make sense? In cigarettes, there is what? Carbon monoxide, which, sorry, that's carbon dioxide. This carbon monoxide, which bumps off this one, the hemoglobin binding to oxygen, right? It bumps it off, and it binds to hemoglobin. So the oxygen, you're not able to deliver the oxygen. And that's what happens with cigarette smokers. Does it make sense? This explains, and this was asked in your final exam and even one of your lecture tests. This explains, can you agree with me? This explains why smokers over time will have a high red blood cell count. It's also referred to as high hematocrit. Hematocrit is the volume of blood that is cell. This measures the cell part of blood. Because we know that blood is mainly red blood cells, the hematocrit really is a reflection of the red blood cell count. Remember, you have millions of RBCs, only up to thousands of 10,000 of white blood cells, and up to 150,000 or 250,000 platelets. So the hematocrit is a reflection of RBC count. Do you understand why smokers will have a tendency to have a high RBC count? Because of the fact that there is carbon monoxide in cigarette smoke. So the carbon monoxide bumps off the oxygen. So you're compromising oxygenated blood. So remember I told you, when you have oxygen problems, the bone marrow is the one that responds. So they just have to make more red blood cells, hopefully supplying enough oxygen here. Because this is key, you need to have a healthy heart. And this is the one that suffers the quickest, right? Because of the fact that they need how many oxygen each trip? 3. Whereas the rest of the body, how many are they unloading? Just 1. You see the difference? Okay? Okay? If you encounter that question in the test, you know how to answer it. Hopefully. Yes? Okay? Okay. So now, let's look at how blood flows. I don't know what chapter in what page in your book. It's called Focus, so it's showing you the flow of blood. I want you to be the blood and trace the flow of blood. I have it here too. Where is it?
If you have the new book, the yellow one.
It's like 29.
674.
Slide 29 does it. Just be the blood.
Yeah, this one here, okay? But it's in your book also. So I want you to be able to trace the flow of blood. What? Okay. In this picture, what you see here are valves. What is the function of valves? What do you think is the function of valves?
Keep the blood from going back.
That's very good. The valves are there to prevent what you call regurgitation. You don't want the blood to regurgitate. valves promote one-way flow of blood. So let's look at, so do you see this picture right here? You see how this valve, and please, I want you to feel that it's so tough. It's really, it does its job. And it's anchored to the heart muscle right here. Okay, there's two terms. The heart muscle in your atrium are called your pectinate muscles. And here it's called trabeculae carne. Carne asada. You eat carne asada. So this
Not
muscle
anymore.
here is called trabeculae carne. You have those names in your book. Trabeculae carne, carne asada. Okay? And this is my valve. If you forget, you just write, it's the valve between the atria and the ventricle. So I say it is an AV valve. That's what they call it, AV valve. So you just write right AV valve, left AV valve. The right AV valve is called the tricuspid, and the left is the bicuspid. It has two cusps. The left is the mitral valve, in case you are wondering. Okay? And if you look at these valves, you see this, there are strings here, like the strings of the guitar. This one anchors it to the muscle of the trabeculae carne. The specific trabeculae carne, where the strings are attached, are called papillary muscles. Okay? So they're anchored right there. You said that the function of the valves is to prevent backflow, regurgitation. I'm going to picture. I'm going to figure out in my head, right? So the valves are open when this atria pushes. So when the atria generates enough pressure, it will push open the valve, right? To deliver the blood from here to here. So now, the next is for this to contract. When this contract, the blood should be moved from here out to my big arteries, right? Not back up here. So remember, when it contracts, you call it systole. When it relaxes, it's called diastole. So when this contracts, the ventricle goes into systole, can you picture? It's going to push all that blood. That's when the pushing of the blood will cause these valves to close like that. And push open the valve here so that the blood goes out here. And that's the importance of these cords. These cords make sure that the valves, they don't evert. It's called eversion. One more time. When the blood is down here in the ventricle, and the ventricle goes into systole, or it contracts, that contraction, so imagine the blood causing turbulence, the turbulence will push these valves closed, right? But when the valves close, you don't want them to go to invert like that. It's like the swinging door. You don't want it to be a swinging door. Then the blood goes up here. That's why these chordae tendineae are very important. The chordae tendineae prevents that swinging or eversion to happen. When the valve closes, it just closes shut like this. So when it closes shut, the blood goes out. My aorta or my pulmonary arteries. Did you get that? So when do the valves close? During systole or diastole?
Systole.
Systole, right? When it's contract. When it contracts, the contraction plus the squeezing of the blood will promote closure of this valve so that the blood will move out here. Have you heard of strep or rheumatic heart disease, right? If you've ever had a sore throat, we always say, especially nowadays, they always say, go have your throat checked. And even if, no matter, any clinic now, they always have the portable or the easy strep throat check, the throat swab. They do that instantaneously in the clinic. And the reason is this threat of a rheumatic heart disease down the road, right? If you ever had a sore throat, you want to always have it checked, because strep that is untreated, they like to take up residence here in the chordae tendineae, in the valve area. This is their favorite area of residence. And when it comes time that you're immunocompromised, they can multiply. And when they multiply, can you predict the consequence? They will cause what you call prolapse, mitral valve prolapse, or valvular problems. And when you have valvular problems, you're going to have problems with pumping of the blood, right? So this is why patients with sore throat, you always send for throat swab. It's more than likely nothing but what if. It's always that what if. Especially if you see some pustules in there or pus. You always want to make sure any redness, like nodule plaques in there, you want to send it. And send the patient for throat swab. You understand? Okay? So I'm going to trace the flow of blood. The blood returns to the right side from a vein, the superior vena cava and the inferior vena cava. So when you do your heart dissection, have your knife and a probe, a blunt probe. So you open it up and then you use your probe. I know, does it make sense? The atria, because they are receiving chambers. The openings that will be from the atria, they must be from veins, because veins return blood into the heart. So I'm going to identify first the chambers. I'm going to say this is the right atrium. Then I'm going to poke. I'll see two openings. These are veins. This is the superior vena cava and the inferior vena cava. And they return the blood to the right atrium. Okay? There's another tiny opening called the coronary sinus. That's a vein that's returning the blood also to the atrium. It is low in oxygen, right? It is deoxygenated. So this is going to move to the atrium, the right atrium. And once it has received, the pacemaker will stimulate this and it contracts, open this valve, deliver the blood here. In the meantime, the pacemaker keeps moving. The next to be stimulated will be the ventricles. The ventricle contracts. The contraction of the ventricle systole will close this AV valve and deliver the blood to this is from the right, it's going to go to your lungs. So it's a blood being delivered away. This is an artery. Going to the lungs, I call it pulmonary artery. You see how it separates into two because you have two lungs, right and left. And then when it goes to the lungs, the pulmonary trunk, it will pick up oxygen and unload your carbon dioxide in your lungs. Then it's going to return to the left side. This is a vein, right? Return to the left atrium. So that's what I'm going to do. I identify, I know this is the left atrium. I poke with my probe. I see openings. I say this is the pulmonary artery. You have 4 of them from the right and the left lungs. It's carrying oxygenated blood. And so the This one fires again, contracts, deliver it, the AV valve opens, the left AV valve, deliver to the left ventricle. The pacemaker moves, this fires, it contracts, closes this, and deliver the blood out. This big blood vessel here is the aorta. So the aorta is going to deliver oxygenated blood to the rest of the body. And this happens, what? 80 times a minute for some. For some, how many? Maybe less, maybe more. It happens constantly. It's very, very well coordinated. Okay? I want you to trace the flow of blood like that. Then when you get to the next chapter, we're going to add blood vessels. So there are two parts to the study of the heart then. There are two parts to the study of the heart. What do you think? One is the conducting. It has its own nervous network, right? I told you. So we analyze the health of the heart in terms of its conducting ability, chronotropic. You know the chronogram, the watch? So that's how I try to remember. The chronotropic part of the heart is the beating. Caused by what? The pacemaker. We can also analyze the health of the heart by analyzing its pumping. How strong it's able to pump or contract. Inotropic. If you have any heart patients, you notice they're not just on one medication. There's usually two or even more. One always addresses this, the other one will address that one. Maybe you have someone on verapamil, which is a calcium channel blocker. Then you see them also on beta blockers. Beta blockers control the rate. It slows the heart rate. So I know beta blockers are chronotropic drugs. I know calcium blockers must be my inotropic drugs. What does chronotropic again mean? Beat, right? The rate, the heart rate. What does this mean? The pumping or the beating. Contraction. Inotropic is contraction. Yes?
What's chronotropic?
Is the rate. So think chronogram, the watch, tick, 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 tick. I remember, I'm having flashbacks of your test. I remember in the past, I always had a section where I will have, let's say, several instances, scenario, and you tell me if this drug causes an inotropic effect or a chronotropic effect, and you tell me if it's a positive inotropic or positive chronotropic or negative. So let's say increased blood volume. What do you think will increase blood volume affect? The chronotropic or inotropic?
Inotropic.
Inotropic, I'm going to write inotropic, positive or negative? Positive means it increases it, or negative means it lowers it.
Positive.
Yes, very good. Okay, how about maybe I'll say increase thyroid hormones. Thyroid is your metabolism hormone. So will it be inotropic, chronotropic?
Chronotropic.
Positive or negative?
Positive.
Positive.
Very good. How about, so you will maybe, I don't know, maybe, how about low hypocalcemia, low blood calcium levels, hypocalcemia.
It's chrono. No, wait a minute.
What do you think?
Inotropic.
Inotropic, positive, negative?
Negative.
Yes, negative, right? It will slow down. If your calcium is low, right, your heart will, the pumping will slow, because this the calcium induced calcium release. How about, let's say, alcohol? Alcohol intoxication. Or maybe anesthesia. Negative what?
Inotropic.
Inotropic and chronotropic, right? So you can actually in some of them I analyze your answer. If you say, let's say, inotropic, as long as it's correct in positive or negative, you can still be correct. Do you understand?
Yeah.
Okay. Okay.
So chrono is the rate and I know is how strong. Or
That's
is it the other way?
correct.
Okay.
Very
So
good.
your respiratory, when you're or watching your respiratory breathe, is that inotropic?
Respiratory is not.
Oh, it's not.
No, not part of. We're just talking about.
So I'm confused if your calcium is hypo, you said your calcium is low,
Yeah,
but you want to give them
hypocalcemia.
an inotropic drug,
No,
which
no,
is
no,
a
no, no.
calcium blocker? That doesn't make sense.
Huh?
No, no, I'm
I'm
not.
confused.
No, I said what will be the effect of these following instances to the heart.
Okay.
So if you have hypocalcemia, if your calcium is low, I'm thinking the pumping of my heart is going to be compromised, right?
Okay.
Because the calcium is the key for heart to pump.
Okay.
So it will cause a negative inotropic effect on the heart. How about if you have beta blockers? So if you have beta blockers, what do beta blockers do? It
Slows the heart rate. So it's
So
going to
it-
be chronotropic.
negative.
Negative.
Very good.
But I have a
Negative.
question. If you have the low calcium and it slows down how hard it's pumping, wouldn't it increase the rate to try and make up for it? Wouldn't the heart try
The
to
rate
increase
of
the
what?
rate?
The heart rate.
Yeah.
Yes, that is a consequence. Very good.
So you
But
would have an ino negative and a chrono positive.
positive. But that will be, that's very good. Very good. But you want to write, for me, for our test, you want to write the immediate. So you can write a long letter to me. You say, initially it will be, and then this will be followed by positive chronotropic. And that's good. See, you're understanding. You see that? You understand chronotropic and inotropic? You know, these are the two drugs that you're gonna see when you're treating cardiac patients. You're either helping the beating part or you're helping the heart, the pumping part, the rate or the pumping, rate or pumping. If you forget what this means, you just ask me, I will remind you. In case it comes out, I'm not sure. Maybe. But if it will come out, it's like this. I will have scenario like this, and then you just tell me, is it mainly the first immediate effect, would it be an inotropic or chronotropic, positive or negative? How about when you lost blood, so low blood volume, hypovolemia, low blood volume. The initial effect will be this one, right? Negative inotropic.
And then the chronotropic positive.
Will be positive. Very good. Okay? Okay? By the way, don't forget, even though the heart is autorhythmic, I told you it beats on its own, right? Is the nervous system also important? Yes, right? Like, let's say you're exercising. You need your heart to beat faster. Here is where the nervous system and the endocrine system come into play. They adjust so that you're able to adapt to any kind of activities. Or maybe you saw your child. You saw your child crossing the street, and then there's a car. You just all of a sudden, your heart races. What causes all of those changes? The endocrine and the autonomic nervous system. But the heart beats on its own. Okay? So, because of the fact that the heart has its own pacemaker, we look at the health of the heart, we can use an EKG to look at the health of the heart. So when I see an EKG like this,
Looks like you have a spike.
yes, I'm looking at waves, and this is telling me something about the health of the. An EKG can tell me some, give me a reflection of the heart rate and also the pumping of the heart. If you have exaggerated waves, I know that the heart is pumping very hard. And if you have segments closer to each other, I know that the heart rate is so fast. Does it make sense? Right? So an EKG is just a strip that just repeats and repeats and repeats. See? It just repeats, repeat, 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 repeat. So if I always look at two like waves, and then if they're closer, I know that the heart rate is faster. So what you need to do is to train your eyes on how a normal EKG looks like. You see abnormal waves. Oh, I know that the heart is trying to beat or pump stronger than normal. That's abnormal, right? You understand? Okay? So I want to look at what are the components of a normal EKG. So there are what you call waves. The first wave is called a P wave. The P wave is the wave. So this measures your pacemaker, right? So the pacemaker, when they stimulate the atria, they cause that wave. And that's why it says atrial depolarization. So the P wave reflects the atrial depolarization. What happens after you depolarize the atria? It will contract, right? In the meantime, remember the pacemaker keeps moving. The next wave is called the QRS wave. This is when the ventricles depolarize. Ventricle depolarization, the QRS. What happens when you depolarize the ventricles? Immediately after this one, they will contract. So after P wave, I know somewhere here the atria contracts. I know somewhere here maybe the ventricle contracts. And then after that, the ventricle relaxes, repolarizes, and another round again. Do you follow? So a normal EKG wave should look like this. There's a cheat sheet, okay, or not cheat sheet, but it's a guesstimate of the heart rate of an individual by looking at the peak. So if you look at this one, you'll see that there's the big boxes, and then there's the small boxes. Okay?
The P wave's missing. The P's missing.
That's very good. But very good. But we're going to look at the heart rate first. I want you to know this one: 300, 150, 100, 75, 60. So how do you, because in your heart test, which is not your upcoming test, right? Your first test is endocrine and blood. Then your second test is heart and blood vessels. So when you get to the heart test, I usually give an EKG and I ask you to give me the heart rate or guess the heart rate. You pick any two like waves, right? And you count the number of big squares in between. If there's one big square, then you see the next wave, it's 300. If there's two big squares, the heart rate is 150. If there's three, it's just a guess, 100. That's how they guess for the heart rate. Then if there's 4, 75. If there's 6, 60. That's how you guess. It's just
Is that
an
in
estimate.
between each
Right?
QRST?
Just pick whatever. You can use this one, any same
So
light
Oh,
wave,
okay.
any light
3,
wave.
4, 5.
So that's 5. 1, 2, 3, 4, 5. About 60. I'm going to say it's about 60. Okay? So I'm going to train again. Look at this EKG. This is normal. I see the P followed by QRS, then T. then P, QRST, P, QRST. This is normal. So, look at this one. What was absent here?
The P.
The P. I don't see the P. It's absent. QRST. So, what this is telling me is the pathology is where?
In the AV.
In the atria, right? So, there is what you call a block.
SA node.
That's very good. This is showing me that the SA node must be dead. It's not firing. So the infarct, MI, the infarction or the dead part of the heart of this patient is up in the atria. It's not firing. But do you agree with me? You look at where the atria is. The atria is superior to the ventricle. Do you agree? So if you have an atrial problem, it won't be too much because by gravity, don't you think?
It'll fill.
That's correct. By gravity, the heaviness, the weight of the blood that enters there, it will still open up those valves, right? Like when the rain and you have like a tarp, eventually you're going to cause that water will break open the tarp. That's the same thing here. So this patient with a block here still will be able to manage daily because the ventricles, look at the ventricles are still healthy. I'm looking at, I want you to train your eyes on a normal, okay? Then look at this one, okay? Look, I can tell where the block is. So I want you to train your eyes on these two, AFib and VFib. You know bradycardia. Bradycardia means slow heart rate below. What is your book? We want to follow the book. What is the book? I think the book says below 80 is bradycardia, right? And more than 80 is tachycardia.
Really? Below 80?
Yeah. We want to follow the book, whatever the book says. Okay? If this is wrong, let me know. And more than, they're always depending on what we're reading. So tachycardia means
thought it was less than
increased
60.
heart rate. Okay? What is it in the book? Go to the index.
Slower than 60.
Oh, 60. Okay, sorry. That's bradycardia. And then more than 60 is tachycardia. Okay.
No, more than 100?
Yeah, it says
I think more than,
more than
Oh,
150.
that's right.
More than
Sorry,
100.
because 60 to 80 is normal. Hello, where did the normal go? More than 100 is tachycardia.
Like I've been doing this wrong all this time.
Oh no.
So 60 to 80 is okay. Thank you. So that's okay. Now look at. I want you to train your eyes on these two. If there's anything, at least it's very easy to know this one and this one, right? You just look at the waves. Then very easy to know normal EKG. Then the next, I want you to train your eyes on this and this. The others where there's abnormal waves, you just know there's like an enlargement or hypertrophy anywhere. This one, look at.
Atrial and ventral are easy because the atrial just has the reversed
That's
PQRS,
very good.
and ventricle just sits there and goes.
Yes, very good. Look at when you say you are in AFib. When you are in AFib, the atria is contracting to the point that it's not strong enough that your waves are not being picked up. So you're going in AFib. But you see, your ventricles are still, your problem is in your atria. So the ventricles are still able to pump blood. Yes? When you are in VFib, look at this picture. I don't see an actual nice shaped QRS complex.
That's a shockable rhythm.
So, yes, which of the two, my question, which of the two is more dangerous, this or this?
The bottom one.
Yes, VFib. Because if you think about it, right, if you're going to AFib, no problem. I said, this is just going to dump it to the ventricle. It's the job of the ventricle to deliver blood to the rest of the body. Yes? This one, when you're going to VFib, is it able to deliver blood? No. This one, if you see this, it's going to go, the patient will die if you don't correct this
It's gonna flatline.
immediately. So AFib, they maybe put you, your problem, they will put you on pacemaker, but in the meantime, they want to give you blood thinners. Because anytime there's like this, there's possibility for slowing of blood. It's not being pushed, so they will clot, right? So you want to put them on blood thinners. But this one, you want to call and
It's a
just,
code.
yes. So train your eyes. I remember in your heart test, I had EKG. And people are like trying to write down important whatever. You just say, or no, I think I have a matching type. Which one is AFib? Which one is normal? Which one shows a block? What's the heart rate? Okay. So there's another part to the study of the heart, which we're going to study on Wednesday, because your brain cells are fried. Okay? So for now, what I want you to do is just go ahead and open up your cat, and I'll give you one heart. So how many groups now? Do you only have 2 cats? 3. Oh, you have 3 cats. Okay, so 3 tables. You open up your cats. I want you to appreciate, please, am I just full of baloney? Is it true that the pericardium fuses with the diaphragm? To me, when you see it, you can really explain now and really push your patient to do the deep breathing, all that stuff. Look at where it's located. Is it true that there's a separation between the lungs and the heart? So that if you have pneumonia, it doesn't really affect the heart. And then, for the heart, I want you to cut it in half and identify all the structures. And I want you to use a blunt probe. And really, remember, you have one general lab exam, one lab exam. I may tell you, this group, to talk about the cardiovascular. Maybe I'll tell you to talk about portal circulation. Whatever. So I want you to really, really identify those parts. Use your lab manual to help you, okay?